Good afternoon. The PAHO WHO Office for Barbados and the Eastern Caribbean is pleased to present our high-level webinar, NCDs and COVID-19, Building Back Better Services. I am Faye Cook Nurse, Communications Specialist, and I will be your chairperson this afternoon. We are joined by the Honorable Mulwin Joseph, Minister of Health, I should say, Wellness and the Environment. He's of the Ministry of Health, Wellness and the Environment in Antigua and Barbuda. We have with us Sir George Allen, former Chancellor of the University of the West Indies and Director Emeritus of PAHO WHO, Dr. Anselm Hennis, Director of Non-Communicable Diseases and Mental Health for PAHO WHO. We also have with us Ms. Trudy Griffith, President, Diabetes Association of Barbados, Mr. Henry Hazel, Chief Operating Officer of the Cancer Center, Eastern Caribbean, Antigua and Barbuda. We also have joining us Dr. Sharon Belmar George, the Chief Medical Officer in the Ministry of Health and Wellness in St. Lucia. We have Dr. Silvana Luciana, Unit Chief, Non-Communicable Diseases for PAHO WHO. Dr. Caroline Raditz, Head of the Health Desk, the OECS Secretariat. And we also have Mrs. Maisha Hutton, Executive Director, Healthy Caribbean Coalition. I welcome you all. We welcome all of our guests this evening as well. And at this moment, I will introduce you to Dr. Yetadis Gebre, the PAHO WHO representative for Barbados and the Eastern Caribbean countries. And he will give the welcome and introductory remarks. Dr. Gebre.
Thank you, Madam Chair. His Excellency, the Minister of Health, Mr. Mulwin Joseph. I think I don't see him on the screen, but he will join us. Sir George Allen, Dr. Anselm Hennis, Dr. Sharon Melmar, Dr. Colin Radix, Mr. Henry Hazel, and Ms. Trudy Griffith, and all participants and colleagues, good afternoon. I bring a warm welcome and greetings from Dr. Carissa Etienne, our esteemed Director of PAHO, to this webinar. Since 6 months since the beginning of the pandemic, in a moment of for all of us to reflect on the progress we have made and the lessons we have learned, and to all of us to recommit ourselves to doing everything we can to save lives. WHO has reported more than 200,000 new positive cases per day for the past 3 days since July 4th. It took us at this point in time a week for the total global case to go from 10 million to 11 million. We have already lost so much, over 500,000 lives, and the economic cost of pandemic has led nearly 60 million people globally into extreme poverty, a global loss of the equivalent of 400 million jobs, an economic crisis with 5% of contraction of the growth globally. But we cannot lose hope, as the Director General of WHO said. This is a time for renewing our commitment to empowering communities, suppressing the transmission. As you all know, people living with non-communicable diseases are heightened risk of becoming severely ill or dying from COVID-19. And the latest data shows massive disruptions in access to NCD services worldwide, which threatens the long-term upsurge in death from NCDs. Recognizing the interconnectedness of COVID-19 and NCDs, there is an urgent need to coordinate and cooperate all aspects of NCD components and then COVID-19. In this, we need to have a public health response, implementation of preparedness and response policies, response financing, management of essential supplies, procurement, data analysis. In Barbados and the Eastern Caribbean countries, we have observed suppression of the first wave of COVID-19 cluster of cases after importation. However, in the recent times, with the opening of borders for international travel and repatriation of nationals from countries with high community transmission, an increase in importation of COVID-19 cases has been observed, potentially triggering a second wave. The reproduction number of COVID-19, which means the measure the transmissibility, is naturally about 2, which means it has an epidemic potential to take off if we allow it to. And in this case, the disease pattern and the case surge remains potentially true so far across Barbados and the Eastern Caribbean countries. The severity also remains consistent. We know that the virus causes a range of illness, with the majority of people having experienced mild symptoms and 20% or more severe diseases. What is important at this point in time for the countries is to reduce the transmissibility and severity of the virus by putting in place public health measures in the whole of society or whole of government approach. To help us understand the interplay between COVID-19 and NCDs, to share experience so far and to guide us from their technical expertise to build a better NCD services, we have invited distinguished leaders in the area of NCD and public health for this afternoon. I thank each one of the speakers, panelists, lending their most valuable voice and time to help countries to decrease morbidity and mortality of people living with or affected by non-communicable diseases through this webinar. We at PAHO will continue to do everything in our power to serve and then countries with science, solidarity, and solutions. Thank you very much for your participation and being here with us. Thank you.
Thank you very much, Dr. Gabriel. Next, we have the Honorable Molwyn Joseph, Minister of Health, Wellness, and the Environment in the Ministry of Health, Wellness, and the Environment of Antigua and Barbuda. I invite the Honorable Minister to make his presentation. Mr. Joseph, please let us know if you can hear us. I will move on to the next speaker. I believe Minister Joseph might be having some technical issues. I will move along to our next speaker, or feature speaker, I should say, Sir George Allen, Director Emeritus, the Pan American Health Organization, World Health Organization, and former Chancellor of the University of the West Indies. Sir George, it is a pleasure. We look forward to your presentation.
Thank you very much, Chair. I'm making a note of the time. Thank you very much, Chair. Dr. Gabriel, all of my friends and former colleagues and current colleagues, Dr. Radix, especially hello to you, ladies and gentlemen, good afternoon. First of all, thank you for having me participate in this webinar. There's no doubt about the magnitude of the problem. And there's also no doubt about the fact that according to the current data, the Caribbean has done reasonably well, I would say very well, in terms of its handling of the COVID pandemic. And from my situation, when I look at the data, when I listen to the various presentations and try to distill some of the essence of why the Caribbean has done very well, one of the things that stands out to me very clearly is the whole area of the commitment at various levels. The commitment at the political level, the commitment at the technical level, the commitment of organizations like CARPHA, of the Pan American Health Organization, the commitment of the Ministries of Health and the governments themselves. But perhaps above all has been the whole area of communication. I have been impressed that in the Caribbean, the credible, consistent communication that has come from all levels. And I think this is one of the features, I think, of the Caribbean response, the communication that has been so consistent at all levels, how credible it has been, how consistent it has been. Of course, one of the, let me see if now I can get this now done. You know, having done this before, I am now going to mess it up. David, what have I done wrong?
Dr. Aline, right, so look for your PowerPoint presentation on your screen.
I had it up on my screen just now, it disappeared. Oh my goodness. Let me get back to it.
There you go.
Let me get back to it.
To your left, right there.
Let me get back to it.
There we go.
Right.
Okay, now if you can put it on presentation mode.
Screen.
There you go.
Yes.
Excellent.
Now, I mentioned communication. Of course, there's probably no better communicator, or one of few, no better communicator in the Caribbean than the Prime Minister of Barbados. And in a very impressive address before the World Health Assembly, I extract this from her presentation. She said then, there was life before COVID-19, and I know that will be life after COVID-19. For this reason, even with the pandemic, we must not drop the ball on those other global health priorities that are critical to our overall development. I refer specifically to the chronic NCDs, which she dubbed the silent killers. So for the few minutes I have, I'm going to build on her presentation. Much of what you will be discussing will be how the Caribbean has dealt with COVID, what are the lessons that have been learned. But what I'm going to try to do is to look more at the life after COVID. What is going to be necessary for the Caribbean to put in place in the life after COVID. Yeah. In order to do this, what I have done is look back at the previous great pandemic of this century, the Spanish flu of 1918, look at the current situation and see if there's any lessons we may learn from comparing these. In 1918, the pandemic killed 50 million people, and the major mortality risk was age. The average age of death was 28 years. It killed the young people. But we should note that the life expectancy in 1900 was only 31 years. And when you look at the data, the mortality data for 1918, NCDs was not a mortality risk. There was no mortality risk from NCDs. But if you look at the current situation, SARS in 2003, MERS in 2012, and now COVID-19, the majority of deaths are over 60 years. The persons over 80 have the highest mortality rate. And we find out consistently across the world, NCDs and obesity are the major mortality risk factors. And we have to look to see, is this the increased prevalence of NCDs, increased life expectancy? And we know that both of those things are true. So when we look at what to do post-COVID, in the post-COVID-19 period, we have to take account of the increased prevalence of NCDs and the increased life expectancy. There is no doubt about the increased prevalence of NCDs. This is the hypertension taken from circulation, and this is so all over the world. It is so for all of the NCDs. The prevalence is increasing as we get older. So the older population is more likely to have NCDs. That's a fact. So when we plan for post-COVID world, I like to say that there are three uncomfortable truths which we have to face. 3 uncomfortable truths. One is that the world and the Caribbean will continue to age. We are not in the 1918 with a life expectancy of 30. Our life expectancy now is over 70 years globally, and the Caribbean it is much higher than that. So the world and the Caribbean will continue to age. The other thing that is an uncomfortable truth, NCDs will always be with us. Like the poor, they will always be with us. And third, there will be another infectious disease pandemic. Absolutely no doubt about this. Dr. Jeremy Farrar, who was the head of the currently head of the Wellcome Trust, and an amazing series of data for collecting some 170,000 samples from all over the world. And he found that was some 1,200 new viruses in those samples. And of those 1,200 viruses, over 160 were potentially zoonotic. Over 160 viruses could possibly infect mankind. So it is not if, it is not when, it is not if, it is but when and what will be another infectious disease pandemic. So we have to take account of those 3 truths in planning for a post-COVID world. Our aging population, the fact that NCDs will always be with us, and that there will be another NCD pandemic. The world is continuing to age. As you see the world population group here, the purple line, can you see the purple line is 65 plus, going up steadily, steadily, steadily. And the youngsters, not the 14, they are coming down. And if we look at the Caribbean, we see the same trend. If you look at 1970, 2016, a projection to 2050, children, the percentage of children going down, working age population going up a little, and the older population, 60 plus, at my age, 60 plus is a youth, but never mind. The older population, 26%. In the Caribbean, the fastest growing segment of the population is the persons over 80 years. Now, if you take these into account, how then must we build back better? We must build back better by improving the management of the existing NCDs. I'm not going to dilate on this. Dr. Hennes, Professor Hassel, Dr. Radix, all can tell you all about how to improve management of existing NCDs. There are lots of guidelines from CARFA and from PAHO on how to manage NCDs. But what I would like to emphasize in the management of NCDs, what I would like to propose that we think of what I call the rectangularization of the lifespan. In other words, that you should young, get to adulthood and maintain a fairly steady lifespan and then a sudden decline. That you should have an NCD-free lifespan and compress morbidity into the last few years of life. In order to do that, you need a life course focus. You need to focus on the things that can prevent NCDs as early as possible. The things that can prevent NCDs as early as possible. So in the post-COVID world, there has to be obviously attention to maternal health, not only from the point of view of the health of the mothers, but there's all good evidence that maternal health is a contributor to the possibility of their children developing NCDs later on. And children, adolescents, and young adults, I can't emphasize too much the 2 major factors in these youngsters that predispose to their being NCDs later on: smoking and obesity. I could spend the whole time talking about obesity and the fact that our Caribbean children are getting fatter. And I would like to emphasize what I've said over and over again. The Caribbean countries are signatories to the rights of the child. And it is a negation of the basic rights of children to allow them to become obese. I think when our governments allow our children to become obese, they are a negation of what they're signed to in terms of the basic rights of the child, the basic rights of the child. So before the next viral pandemic arrives, however, there's one other aspect which I like to emphasize. which has been in a large part responsible for the good performance of the Caribbean health systems, good performance of the Caribbean in terms of COVID. And that is to ensure that our systems are resilient in the sense of they do well now and they'll continue to do well later on. There are lots of characteristics of health systems, but for the Caribbean, I like to emphasize 4 characteristics that I think are essential for us to keep in mind. 1, our health systems must be aware, provide information which I contend is the lifeblood of public health. And we are fortunate in having CARFA as our center, which has been so helpful in strengthening the information systems of the Caribbean countries. Our health systems have to be aware. They have to be agile. They have, and you will discuss this during the coming presentations, they have to be able to respond to the urgency of the Zikas and the Dengues, as well as respond to the non-communicable diseases. They have to be adaptive, in a sense, depending on the nature of the threat that before us. When there is a hurricane, our health systems have to be able to adapt to the aftermath of the hurricane. And also our health systems have to be articulated. And if we are going to be faithful to the dictum of universal health coverage, this articulation of health systems is critical indeed. One of my favorite gurus used to be Peter Drucker. And he said, unless commitment is made, there are only promises and hopes, but no plans. And what I would like to see from this webinar and from the other things that are taking place in the Caribbean, that commitment is made to ensure that in the post-COVID world, we are able to deal with the health issues that arise. Just as I was preparing this, someone sent me this information, and I saw this, that we can feel good at the end. The best performing COVID-19 recovering countries in the Americas, Dominica, Barbados, and Uruguay. I think one could include many other Caribbean countries and those that have performed very well. And that performance is due in no small part to many of you who are participating in this webinar. Thank you, Chair.
Thank you very much, Sir George. I'd like at this stage to acknowledge the presence of Dr. Sharon Belmar-George. Acknowledging the presence of Dr. Sharon Belmar-George, the Chief Medical Officer, Ministry of Health and Wellness in St. Lucia. And at this stage, I'm seeing that we are joined by the Honorable Molwyn Joseph, Minister of Health, Wellness and the Environment in the Ministry of Health, Wellness and Environment in Antigua and Barbuda. At this stage, Minister Joseph, I'd like to invite you to make your remarks. Minister Joseph. Yes. Of course, in these demanding times, we have to give our leaders an opportunity to attend to the matters of the day. So now that Minister Joseph is taken up with an urgent matter, I will move right along to our next speaker. I'll introduce you to Dr. Anselm Hennis. Dr. Hennis is the Director of Non-Communicable Diseases and Mental Health for PAHO WHO, and he's based in Washington, D.C. At this stage, we invite Dr. Hennis to present on the results of NCD service delivery and COVID-19 surveys. Dr. Hennis, welcome.
Yeah. Thank you very much, Madam Chair. I will ask your coordinator to put my slides up if that is possible. Or shall I go ahead and do it myself?
You can try yourself, Dr. Hennis.
Right.
Where you see share screen at the bottom?
Sure, let's just pull that up. Sorry. Okay, let's pull that up.
Yeah.
Share screen. Okay.
And then a window pops up and you select your presentation. And then press share.
Sorry.
I can do it for you, Dr. Hennis. 1 second, please.
Okay. Good. Wonderful. Okay, thank you so much. Well, it's a pleasure to be here, as it always is. So my brief this afternoon is to speak about the results of NCD service delivery and COVID-19 surveys. So let's go to the next slide. So basically, as noted, 2nd of July of this year has been 6 months since the first reports of 27 cases of unidentified pneumonia came to us from Wuhan, China, with a potential link to a local market. In the last 6 months, these initial cases are now grown to 10.7 million cases worldwide, with 500,000 deaths across nearly every country or territory globally. What we still note is that in 86 countries, there's reporting still of community transmission, which indicates large outbreaks of local transmission, large numbers of cases not linkable to transmission chains, and multiple unrelated clusters in several areas of the world. So as the numbers continue to increase, we're seeing transmission in countries such as Brazil, Mexico, India, and the United States. Let's go to the next slide. Thank you. And therefore, what is just reiterating is that the situation has changed drastically at a global perspective since the onset of the pandemic. The first epicenter was in Wuhan, China. There was a strict lockdown with 11 million inhabitants confined to their homes, which lasted for several months. Then it moved into Europe, Italy, and France at the beginning. Now it's spread over to the United States of America, and it's now shifted into Central, particularly in South America. Let's go on to the next slide, please. Good. Now, in the region of the Americas, COVID cases continue to occur at a rapid pace in many countries and territories. The United States continues to lead the world and the region in cumulative incidence of cases. And it has recently alternated with Brazil as the country reporting the highest number of cases. The 7-day rolling average of daily cases in the region of the Americas as of the 2nd of July was 105,000 cases compared to the 25th of June when it's 88,000 cases, which is an almost 20% relative increase. Let's go to the next slide. And this speaks to the epi curve of deaths, but it needs to be interpreted with caution because there are a number of biases, particularly biases in delays in reporting, differences in case definitions. There's a scarcity of testing and deaths that occur outside hospital premises, such as at home and nursing homes. So really, we believe again, as with cases, the deaths are underreporting. Let's go on to the next slide. So this here tells you the story as of the 3rd of July, where globally there are 5.5 million cases and 250, in the region of the Americas, there are 5.5 million cases known to us and 260 or so thousand deaths. Breakdown by sub-region is highest in North America, 3 million plus, Central America about 90,000, South America 2.4 or so million, and the Caribbean 60 or so thousand. Let's go on to the next slide. Now, right away, we've discovered, as Sir George had intimated, that there are now links between this infectious disease pandemic and non-communicable diseases. We know that persons with underlying conditions such as cancers and chronic kidney disease are at higher risk of developing COVID-19. And in fact, as also mentioned, we're seeing more severe cases of COVID-19 with a number of risk factors and NCDs, including hypertension, cardiovascular disease, factors such as smoking, lung disease, cancer, chronic kidney disease, among others, including obesity. And again, as Sir George said, old age remains linked to COVID risk, as well as higher risk of death in terms of old age, hypertension, diabetes, COPD, chronic obstructive lung disease, and cardiovascular diseases. And what this has also really revealed is the fact that a number of population groups who are at greater vulnerability, who have higher prevalences of these diseases, are also being manifested as having a greater risk of COVID and poor outcomes, as well as being linked to lower socioeconomic status. So we're now seeing a number of other interactions and intersections between health, society, and the economy. Additionally, we must not forget that mental health issues are also of great significance. While we're not addressing that this afternoon, we must not forget the potential impact in mental health. So I'm going to speak to you specifically about an assessment of COVID-19 on NCD services, and I'm reporting for the Americas. And what we did was that we shared a standardized questionnaire to all the countries, all 35 member states. We also had a web-based questionnaire to assess the impact of COVID on NCD staffing, service disruptions, data collection on comorbidities, as well as suggestions for WHO technical guidance and tools. We collected data during the month of May, and we received responses from 27 of 35 member states in the Americas. At the global level, 155 of 194 member states reported for a response rate of 80%. Let's go on to the next slide. So this speaks to reassignment of NCD staff in response to COVID. And in the region of the Americas, there was only about 4% of NCD staff who were not reassigned at all in response to COVID. 33% of staff were partially reassigned. These are people dealing with NCDs, or some NCD staff were partially reassigned in another third of cases. And in about 7%, all NCD staff were reassigned full-time in response to COVID. Let's go on to the next slide. Now, it's not just reassignment of staff, but also disruption of essential NCD services. And this slide speaks to the percentage of countries where outpatient services were disrupted as a result of COVID-19. So outpatient services were open with limited access or staff, or held in alternate locations or where different modalities took place, and in as many as 67 or 2/3 of all the countries where they reported on non-communicable disease services. Services were, however, open in about a quarter, or NCD outpatient services were closed in just less than 10%. So we can see in 2/3 of cases, there was impact from COVID-19. Let's go on to the next slide. What are some of the strategies to overcome NCD service disruptions? One, triaging to identify priorities. Now, what does that mean? Clearly, you cannot see everyone the way you did before the onset of the epidemic. So therefore, there were attempts being made in terms of seeing which patients really must be seen first and trying to prioritize those patients for continued care. But on the other hand, what we in fact did see was that a number of people were afraid to go to medical services, and in spite of having the opportunity to do so, did not do so. I will speak a little bit more about that in the second presentation I'm going to do. Telemedicine deployment to replace in-person consults took place in many 60% of countries. But in fact, when one tries to ask the question a little bit more, with a bit more granularity, you may find for a large country, they say, yes, telemedicine was deployed, but it might be only deployed in the major cities where there's capacity to do so. And we see quite quickly the urban-rural divide where services were constrained in rural areas. Novel supply chains or dispensing approaches for NCD medications took place in about 55% of countries. And again, I'll speak a bit more to this. But for example, things as simple as making medications available for a 90-day period rather than a 1-month period made a tremendous positive impact on the whole situation. Redirection of patients with NCDs to alternate healthcare facilities was reported in half the countries reporting. And of course, that is prioritizing your health services. So then patients who are at low risk are able to seek care in other places with the prioritization for those who are likely to have had COVID. And of course, then there's also the whole use of task shifting or role delegation. Let's go on to the next slide. A number of activities were postponed because of COVID. And the one that we saw having the biggest impact was actually implementation of NCD surveys to collect information in as many as 60% of countries that reported. Public screening programs for NCDs, for example, blood pressure checks and so forth, were closed in nearly half of countries reporting. The WHO Heart Technical Package, which is an intervention at the primary healthcare level to improve hypertension detection, control, and management, which we thought would have been a really important mechanism of ensuring delivery of care, was actually closed in about 30% of countries that reported it. Mass communication campaigns, again, were closed in as many as a quarter of countries. WHO package for essential NCD management, training, and implementation of primary health care. Again, the PEN system was closed in about a fifth of countries. So as we can see all the way through, there are different degrees of disruption in various NCD activities beyond the immediate healthcare system with direct patient practitioner interaction. Let's go on to the next slide. And this is a list of what the member states requested of WHO. They asked to have communication materials, and they asked specifically to have public education messages on COVID-19 and links to NCDs and risk factors so they can learn more and understand linkages with this new epidemic. They asked to have social media messages and promotion of healthy eating and healthy lifestyle during confinement, because when you're basically confined to your home, you have to continue living. And so they wanted guidance about how this could be achieved. Also in terms of data, really very important, as Sir George himself said in his presentation, information, the lifeblood of public health. So we are working on things like modeling and projections of the impact of COVID-19 on NCDs, risk factors, and NCD mortality as part of what the countries ask and need. Guidance how to collect data and NCD-related comorbidities in COVID patients. And this is why we're learning more about the implications and the impact of COVID-19 on pre-existing conditions, and how to register and report underlying conditions in those who die from COVID-19. So a lot of new demands about information, data, modeling, and projections. Next slide. Technical guidance. How to manage people with NCDs and COVID-19. Very, very important. A learning exercise for all of us. And also capacity building. How to build capacity for telemedicine and virtual consultations. Because you're existing in a system whereby social and physical distancing is the way to manage the epidemic. So then how do you start to communicate and offer care in the virtual environment? Virtual trainings, virtual meetings. And this is part of what we're engaging in even as we speak right now. And then also continued capacity building in the area of mental health, recognizing and preventing depression because of the situation of the epidemic due to COVID-19. Next slide. I think this should really be it. So thank you very much for your attention.
Great. Thank you so much, Dr. Hennis, for that presentation. It was quite insightful. At this stage, I'd like to invite Ms. Trudy Griffith. She is the president of the Diabetes Association of Barbados, and she will be presenting on the impact of COVID-19 on service delivery. Ms. Griffith? Ms. Griffith, I am not hearing you. I'm not sure if others are able to hear you.
Okay. I'm not able to share my screen. Good afternoon to everyone.
Good afternoon. Thank you for joining us.
I'm going to be sharing my presentation with everyone because it's preventing me from sharing my screen.
Here we are.
Lovely.
Thank you so much.
Rudy, we just need you to click on presentation mode on your PowerPoint like you would do normally.
Okay, no problem. Wonderful. Okay, so good afternoon to everyone. Thank you, Ms. Cook-Nurse, for your welcome. I want to say thank you to PAHO WHO for inviting me to speak on this topic because COVID-19 has definitely impacted the service delivery of the Diabetes Association of Barbados. So I'm going to share with you what our local experience has been here. I have no conflicts of interest to disclose this afternoon, so we can move straight in to the presentation. So this quote: "The epidemic of NCDs poses devastating health consequences for individuals, families, and communities, and threatens to overwhelm health systems. The socioeconomic costs associated with NCDs makes the prevention and control of these diseases a major development imperative for the 21st century." You would almost think that that's a quote that has been taken from someone here in the Western Hemisphere, but this is actually a quote that was published in The Hindu by an author, Harmala Gupta, who is associated with a cancer support organization within that country. And what COVID-19 has truly taught us is that NCDs has to be at the foreground of global consciousness. There is no argument about that. So what is the landscape as it relates to diabetes in Barbados? Currently, we have a projected population of 287,000 persons on island, and we have public and private healthcare services available island-wide. There is a projection that the prevalence of diabetes in Barbados is between 15 and 20%, but I want to caution you that that number may actually be double, because there is a rule of thumb that for every person who has formally been diagnosed with diabetes, there is at least one person who is undiagnosed. So really and truly, we may be facing a prevalence of diabetes in Barbados somewhere in the region of 30 to 40%, which is quite staggering when you consider that the global prevalence of diabetes is almost 1 in 11 persons, and we're actually looking at somewhere of 4 in 10 if we take the worst case scenario.
Trudy,
No.
may I interrupt? I'm sorry.
Excuse me.
You
Would you
stopped
mind
sharing your screen.
Oh, you're not. Okay, let's go back.
Now to your right, scroll
Yes,
where
here we are.
presentation mode.
No, it's still saying host disabled
There you-
participant screen sharing.
No, we can see it. We can see it.
I am
Okay, no
actually
problem.
sharing it.
Okay, we can see it. Perfect. So if you can go to the slide.
There we go.
There we go.
Okay, so can you go back one? Okay, and let's go from here. Is that okay then?
Yes.
Okay, wonderful. So as I was saying, as it relates to the Diabetes Association of Barbados, our current membership of those persons who have paid their subscriptions stands at about 500 persons. And if you consider the figure that I have just shared with you in terms of the number of persons potentially who have been diagnosed with diabetes, you would realize that there is a discrepancy. I also want to note here that we are open to persons for membership regardless of their diabetes status. So really and truly, we need to be looking at higher numbers for persons who wish to be members of the association and take advantage of the services that we offer. So with regards to the Diabetes Association of Barbados and the services that we do offer, beyond membership, what we do is that we offer persons the opportunity to attend meetings. The programs that we offer are listed on the left of the screen. So we have community outreaches that we provide to corporate organizations across Barbados, presentations. We have a conversation map program specifically for persons who are interested in learning more about diabetes. We have the Sponsored Child with Diabetes program, where we provide tangible support for persons who are diagnosed with type 1 diabetes up to the age of 25. We run 2 camps every summer, which is Camp Pride and Camp Wellness. Camp Pride specifically for children living with type 1 diabetes, and Camp Wellness for those children who are at risk of developing an NCD. Additionally, we provide a number of services, including counseling, the provision of monitoring devices, such as the glucometers and blood pressure machines, and then we do health checks both in our office and at our community outreaches. And what did COVID-19 do for us? It did just about everything. It caused us to cancel everything. We had to close our headquarters. We could no longer have face-to-face meetings and mass gatherings. We could not conduct any education and training. That had to be postponed indefinitely. In terms of our volunteers, we were quite willing and ready to take on quite a number of volunteers, and that had to be deferred until such time as we could resume. All testing and all of the service provision has been canceled. We were not able to conduct any fundraising activities whatsoever. And then we had a couple of initiatives that it was so hurtful that COVID-19 came along, because there were some really amazing initiatives that we were going to embark on. We had a couple of students from McGill University who were ready to come and do their dietetic internship with us, and that had to be deferred. In Barbados, the National Give Back program, utilizing students of tertiary institutions, that had to be suspended at that time. And then we were actually going to be embarking on a collaboration with the Heart and Stroke Foundation of Barbados for May Measurement Month. All of that had to be deferred. So you could well imagine that it has been quite disruptive with COVID-19 on the scene. In terms of our testing trend, this graph shows you the number of persons that we've tested at outreaches as well as at the office. And you can see that up to March, we have been averaging under 100 persons a month in some cases. And then for the months of April, May, and June of this year, that has gone all the way down to 0. So you can see the impact of COVID-19 in terms of one of our services that we offer. One I truly want to comment on, because this is something that was quite impactful for us, was that as much as there's a lot of information out there about COVID-19 across all of the platforms, we found that our members are not engaged with technology. So persons who would have traditionally come to our office or called us on the phone to contact us and get service provision, as well as to be updated on what's going on with the association, they were truly inconvenienced. And that has implications for their personal well-being. What that also highlighted for us that credible, timely information is absolutely essential, because I find that some persons were misinterpreting what was being put out in the media. At the regional level, the Diabetes Association of Barbados is part of the North America and the Caribbean region under the International Diabetes Federation. And we had a meeting via Zoom technology on the 11th of May this year. And these were the questions that we answered from each of our countries' perspectives in terms of what was our perspective on the management of the COVID-19 pandemic. Were there sufficient health personnel available for the needs of persons living with diabetes? Are persons in the country currently receiving support from local and international agencies, including government? What was the supply of emergency medication, including insulin, particularly for persons with diabetes, and what support do member countries need at this time? Now, while I do not have the time to go into all of the answers from the local perspective, I do want to highlight that what happened with COVID-19 is that it has disrupted our supply chains. So therefore, when we're looking at supply of medications for the needs that we have, we found that it's quite disruptive, and therefore it's been quite difficult coming up with alternative treatments for our patients, because COVID-19 has not minimized the other presentations that patients may have for acute medical care. So therefore, it has been quite disruptive. So what have we learned at our organizational level? That we need to be responsive and relevant. we need to pursue alternate means to communicate with members. And it was quite fortuitous that during this period, we were able to start a radio broadcast called For the Health of It. So we utilized that medium to communicate with our members and improve health literacy across the nation. We also need to look ahead at implementing contingency planning for all of our areas of operation. And what COVID-19 has brought to the fore is that we need to evaluate additional options for delivering services, not just to our members, but for the public. What do we need to learn at an international level as well as the national level? We have to invest in better management of NCDs. This echoes the sentiments expressed by Sir George Aline as well as Dr. Hennis. But what I want to really comment on is that it will require intersectoral collaboration, which are not limited to health, finance, transportation, education, agriculture, and urban planning. We really do need all sectors involved to ensure that we are not going to fall through the cracks. And we need to tackle NCDs through a public health approach, which emphasizes prevention, early detection, and timely local treatment at the primary healthcare level. Ladies and gentlemen, thank you for your attention, and you can contact me if you so desire after the presentation.
Thank you so much, Ms. Griffith. And we wish you all the best, along with all the team members of the Barbados Association of Diabetes. At this stage, I believe that the Minister, the Honorable Mulvin Joseph, is able to join us now. And I will first double check. Minister Joseph, can you hear us?
Yes, can you hear me now?
Yes, we can. Yes, we can. Let me introduce you, the Honorable Mulvin Joseph, Minister of Health, Wellness and the Environment in the Ministry of Health, Wellness and the Environment of Antigua and Barbuda. I invite you to present your remarks. Minister Joseph.
Well, thank you very much. And let me first apologize in taking some time to overcome these technical difficulties. I'm really delighted to be part of these discussions. I must commend Dr. Gabriel for arranging this important discussion at this critical time. And let me also recognize the presence of Sir George. I've always looked forward to hearing Sir George, and he did not disappoint today. I'm edified by his presentation, and I also would recognize Dr. Radix from the OECS Secretariat. Colleagues, it's really a pleasure to be discussing this issue, and the experience of COVID has left some lessons for us. And one of the areas that I would like to suggest that be taken on board for discussion is financing healthcare in an environment of COVID and NCDs. I can share Antigua's experience with you. In Antigua and Barbuda, we had 3 deaths, and all deaths were associated with underlying medical conditions of diabetes, hypertension, and chronic respiratory disease. In other words, 100% of the deaths in Antigua and Barbuda is directly associated with NCDs, 100%. The idea also of a lockdown should take some serious evaluation and analysis. The impact of lockdown on NCDs as well as mental health. COVID forced many families in conditions they never experienced in their lifetime, and coping with the inability to live a normal life had great impact on our society here in Antigua and Barbuda. We had a phenomenon in Antigua which I'd like to share with you. We had approximately between 9 and 12 sudden deaths of men in Antigua and Barbuda. Just sudden deaths. We believe that there is a good reason for investigating these deaths in the context of lockdown, in the context of underlying conditions of NCDs, in the context of mental health. And when you add this to the issue of maintaining the services, the medicines that are required under these circumstances at a time when a country's revenue would have contracted, some of us 40%, 50%. The question is, how do we structure our economies? How do we plan financing our healthcare systems, dealing with two important parallel challenges? On one hand, we have to maintain strict management of containing transmission of COVID, and then we have a parallel track of fighting NCDs. One of the things that I believe in Antigua and Barbuda that we recognize as important in terms of financing is the whole issue of national health insurance. And I'd like to put that on the table as something that should be discussed for the future of how we could prepare ourselves for these pandemics. Pandemics will come again. What will be the ability of our economies to sustain reliable financing of health services when economies close down? We are fortunate in Antigua, we have what is called the Medical Benefit Scheme, which is a quasi health insurance. And I'm pleased to say that we were able to maintain reliable delivery of our medicines because we have this quasi insurance. And during the pandemic, the institution was able to be very innovative and make deliveries to our elderly. So there wasn't any major fallout. Now, I do not wish to go on and on because I am looking forward to the discussions where we can exchange ideas. But let me repeat that the Caribbean institutions have served the Caribbean well, and as a result, the Caribbean has performed exceptionally well in the context of the experiences in the world. And I would like to recognize the important work of PAHO, CARFA, the University of the West Indies, SEDIMA, and all the other organizations that prepared us for this pandemic, or the response to the pandemic. We should never forget the early days when ministers of the Caribbean met, and we had the support of the Pan American Health Organization, as well as CARFA, and the support from Dr. Gebre and his staff in Barbados. With those remarks, I look forward to commenting on some of the other issues after the presentations are complete. Thank you very much.
Thank you very much, Minister Joseph. A pleasure. Before Minister Joseph, we heard from Ms. Trudy Griffith, who, as we said before, is the president of the Diabetes Association of Barbados. And let us remember that the purpose of the association is to provide support, advocacy, and education to improve the lives of those at risk of developing diabetes and persons living with diabetes. I will move on now to Our next presenter, Mr. Henry Hazel, from the Cancer Center Eastern Caribbean in Antigua and Barbuda. And this center provides non-communicable disease services such as screening, chemotherapy, and radiation oncology. Mr. Hazel is the Chief Operating Officer, and I invite him to make his presentation. Mr. Hazel.
Good afternoon, everyone. And Madam Chair and everyone, please permit me to adopt the protocol already established. As expressed by those who went before me, it is indeed a pleasure to be a part of this forum. I consider it to be extremely important as we are now discussing this very important topic. Notwithstanding that it was a little bit pressing for me to actively participate, as I am now doing, the sacrifice was well worth it. The exchange of information and the engagement in discussion to deal with issues like this is absolutely important. I consider it to be one of the higher priority imperatives for us going forward as we seek to develop ourselves as a small island states. May I ask for permission to share my screen, please? I was able to put together a very short slideshow, but the host has disabled my participant screen sharing capability.
You should be able now to do it.
Should be able now to do it. Okay.
Yes.
Fantastic. Good. This. Okay. Good. I should find the button to share. Great. Okay, so I am actually looking at cancer care delivery in a COVID period. And I think it is important to state upfront that there is no singular institution or body that provides the entire spectrum of cancer care within Antigua and Barbuda and the wider OECS for that matter, right? So it is a partner care model across various organizations and institutions, including governments as well too. And we sort of try to put together a model as to how we think it should be approached within our context of the OECS. We do have certain levels of capability within each of our respective countries, but because of economics, we have a regional radiation center that services the entire region. So it is in this context that I really want us to look at how cancer services were delivered during this period and how we propose to continue to do so for the benefit of all people. Right, so on screen right now is a little bit of a hub and spoke depiction with the Cancer Center Eastern Caribbean right at the core of that being the hub, simply because it is the single radiation treatment facility for the region. And then, of course, the spokes would be the level of cancer care management that takes place within the respective member states of the OECS, where they do have a very active, very good programs that are going on as well. In addition to radiation, the cancer treatment protocols will include chemotherapy as an additional, and of course, surgery. And these two, for the most part, can be delivered at our government hospitals and in some cases at private medical facilities in the countries as well. If my memory serves me correct, I'm aware that most of our OECS member states have that local capability for chemotherapy and surgery, maybe except Angola and Montserrat, whose patients come to Antigua to the Cancer Center for chemotherapy treatment. Moving on. So the hub is essentially the Cancer Center Eastern Caribbean, a regional cancer treatment facility located in Antigua. Of course, it was built by OECS mandate, became operational since July 2015. The primary site for external beam radiation, as I mentioned before, and the equipment that we use is an Electra Infinity linear accelerator with agility. I'm not quite too sure how familiar or informed the audience is as it relates to radiation machines, but linear accelerators are essentially the standard of care for radiation therapy these days compared to what used to be before the cobalt machine resistance. Yes, so for the OACS region, we are the primary site for external beam radiation. And we do have external beam radiation protocols that provide good substitutes for radiotherapy as it relates to cervical cancer treatment as well, as a very good alternative to that. We could ideally be a main center for chemotherapy, especially when we're talking about chemo, radiation, concurrent treatments. It is very important that those two are properly coordinated, and so we are fully equipped to deliver chemotherapy as well, notwithstanding the fact that all of the member states would have that capability on the local level. And of course, as a radiation treatment center, our specialization, we could actually be the go-to institution to initiate any sort of complex chemotherapy, and then of course assist other countries in that regard. We've been operating for over 5 years now. Had over 600 referrals. We have done over 500 consults and actually treated over 400 patients so far. And as mentioned again, our patients come from all of the OACS countries, with a few that are extra-regional. We've had from the UK, United States, and other countries as well. So the hub, well, this one actually should be saying, instead of the hub, it should be saying the spoke. We are looking at the public and private cancer clinics within each of the member states. There are different levels of development, I must say. Some of the countries are more advanced than others as it relates to their capability to deliver chemotherapy. Some of our hospitals are well equipped, very modernized, and so on. There are others that are only recently coming along, and so that process is continuing. As I mentioned before, Angola and Montserrat, to my knowledge, have not yet developed that capability to deliver chemotherapy on island. Right? So, in the model that we have, we are proposing that apart from the radiation therapy that is regionalized, patients really should not have to leave their own countries, and therefore significantly reduce the cost, minimize the cost associated with them accessing cancer care. So for consultations with the oncologist, that could ideally happen on island. Where an oncologist does not exist on a particular island, our model is for our cancer center oncologists to actually travel to those countries and conduct the initial consultations with the patients there. And for the chemo infusions and so on, yes, we promote that these actually happen at the country level, all towards ensuring that we keep the cost as small as possible for the patient. Right, so talking about now how we actually deliver the services across, cancer services during the COVID period, I think it's important that we look at the cancer services across the care continuum for us to put it in proper context. Right, so I have on screen here what the continuum sorts of look like, and we have prevention and risk reduction, a certain level of activity and responsibility that is at the patient level. Then we come across to screening, which is oftentimes facilitated, conducted, managed by government agencies, NGOs, and even private practices as well too. Then we come across to diagnosis, treatment, survivorship, end of life care for the patients. Right, so screening, for example, and the diagnosis, I think all of us are pretty much aware that because of lockdown measures and so on that were put in place, these were significantly affected. From the Cancer Center Eastern Caribbean perspective in particular, because of these measures, lockdown measures, we were essentially became stationary and we could not move about the way we would normally do. So our travels to the various islands were suspended indefinitely, and our screenings that we would normally do in some islands on a monthly basis, in others on a quarterly basis, like in St. Lucia where we had an office, we did those public screens on a monthly basis, and in Anguilla, where we frequent very often, we did those on a quarterly basis. And so on account of COVID and the government lockdown measures, etc., and flight restrictions, closure of borders, all of that had to be suspended. They are still suspended, and that is, how we have to treat. So yes, those two aspects, very important aspects of the overall care, we believe, were significantly affected in this way. I am sure that, as I mentioned before, we are not the only ones who deliver cancer services, but the level of effort that is normally done by the respective governments as well, I am sure that these were affected in that regard as well. The diagnosis part of it, where we are totally dependent on what comes in from the feeder practitioners, the biopsies, the pathology reporting, the histologies and so on, the staging of cancers, the biomarkers, and the molecular profiling. Right. We do not do diagnosing at the Cancer Center Eastern Caribbean. We just focus primarily for the time being on treating cancer. So all of these other relevant related care activities that are precursors to patients accessing treatment, when these are affected, it really affects the level of activity at the cancer center itself as well too. Right. So lockdown measures actually meant that a lot of these institutions that do these things would have significantly curtailed or even suspended the operations, and individuals were not getting access to these things as part of the entire process. But when we look at, just moving along on my screen here, right, so I mentioned earlier on as it relates to the disruption along the continuum. I talked about the screening and the diagnosis. Our office in St. Lucia closed indefinitely because we could not get there. It is normally resourced by the staff here in Antigua, traveling there on a monthly basis, supported by a small level of local staff in St. Lucia. And our regular clinics had to be suspended as well in the other islands. Right. In terms of the treatment itself that we deliver here at the cancer center, particularly the radiation, interestingly, we actually saw an increase in our patients on treatment during the COVID period, right? Mostly these were from Antigua across all three funding categories. The funding categories that we have are insured patients, self-paying patients, and government-sponsored patients. And just to allude to what the Honorable Minister of Health mentioned earlier in terms of the government support during this entire period, we will actually saw the commitment of the government in terms of ensuring that there was no significant delay or scale back on funding of care for cancer patients who were there waiting to start treatment with us. The medical benefit scheme, which I think is a very important institution, and the minister mentioned, it will all be the better for us all were we to move to full-blown national health insurance, so that cost would not be a key inhibitor for individuals accessing care. Right. During the COVID period, we actually had 3 new patients from Anguilla. One came in May, and 2 of them came across in June. These were very urgent cases, and again, there was a level of intergovernmental, inter-country collaboration that actually made this happen. These individuals were able to come across at a time when the countries were locked down, Antigua locked down, Anguilla locked down, but through a medevac arrangement by private charter as well. They transferred to the Cancer Center Eastern Caribbean, and to be able to access critical care was properly facilitated. And that really speaks to the need, not just for now, but for on an ongoing basis, for a level of collaboration that really needs to happen across our member states in the OECS, so that our citizenry can actually access care that is available. Anecdotally, I could say that there's been a rise. The rising numbers could be attributable to closure of country borders, where our people would normally historically go for care. Notwithstanding the presence of our center here, yes, historically, some of our people would go to North America, United States, to access radiation treatment, and the other treatments as well too. and even to Trinidad and further south as well too. But the closure of these borders, this could be one of the reasons why we actually saw a rise in our numbers of patients and treatment, notwithstanding that we were on COVID lockdown, etc. So individuals who were not able to travel essentially had no choice, quote unquote, but to come to us to ensure that their care actually continued. Surgery and chemotherapy, these are mostly done at the local level, in hospitals, as I mentioned before, and some private institutions. I do not have definitive information on these because I do not manage those. My information is largely from the Cancer Center Eastern Caribbean perspective that I have very full and intimate knowledge of. But no doubt there would have been some levels of reprioritization given the COVID imperatives, and quite understandably so. At the general hospitals, for example, the oncology clinics more than likely would have been affected by what would have been happening as far as patient trafficking through the hospital system on account of COVID. Right, so I would like to end my brief presentation by just citing a few what I consider to be good lessons coming out of COVID for going forward. I do think that it's a golden opportunity for us to revisit, relook, and rebuild. Yes, I would like to even quote from, I think it was Warren Buffett some time ago when we had the global financial meltdown, when he indicated that a crisis is a critical thing to face. And here we have a crisis that we really should take on board, the very important lessons coming out of it. And we definitely would be all the better for it, to actually be very serious about how we could make ourselves, more resilient going forward. So effective delivery of cancer services is dependent on seamless functionality of interconnected service levels, locally, regionally, and internationally. And this we have seen actually borne out at the local level here in Antigua, where the paying agencies, the care providers at the various levels, had to have a level of collaboration to ensure that there were no major disruption in care for cancer patients. At the inter-country level, a good example for us, as mentioned before, was what happened between the government, the Ministry of Health in Antigua, the Ministry of Health in Anguilla, to facilitate transfer of patients who stood in need of critical care. And of course, internationally as well, those functionalities of interconnectedness needs to be there, right? So there are some things that we actually can do within our own space. There are some other things that are, unfortunately absent at this particular point in time. And the things that are absent are those that form part of the diagnostic investigations. For example, PET-CT, we do not have that at all within the OECS region. It is a difficulty for us right now dealing with some of our patients presently who we are trying to see what is the best approach going forward with their treatment. Them not being able to go to Trinidad to get a PET-CT scan or go to the United States at this particular point in time to get a PET-CT scan. So that's a challenge for us. Governments play a critical facilitation role. I think this is clearly obvious, and that really needs to continue and be taken to new levels. There, I think we can accept that some levels of disruption are unavoidable. When we had our first response to the crisis, when government was seeking to ensure that there was proper control as it relates to the rate of infection and so on, and the measures were put in place, it brought about, stoppage to some extent of some of the critical services. But what is important is a swift resumption. And this, I think, is very practical within the context of interagency and intergovernmental collaboration. The communication lines need to be open. All the different institutions and parties need to be aware of all the critical parts, components of the overall, and that, yes, the communication lines are open, and the collaboration, it is where it is supposed to be. Key access determinant is cost, especially for cross-border services. It was not a cheap proposition for those 3 patients to come across from Anguilla to Antigua in this COVID season. Chartering a plane was, I think, $2,500 alone. That's by itself, and we're not even talking about the cost for the treatment itself as well too. Just to make another example, analogy, we recently investigated access for a patient going to Trinidad for PET-CT, and the cost that we are being quoted for chartering a flight, because the airports are still closed between Anguilla and Trinidad. That's Anguilla patient we're looking after right now. Those airports are still closed, and one of the options is to go via Medivac / air charter. And the minimum cost for that charter flight is $16,000, right? So that presents as something that is extremely prohibitive and presents us with a major challenge. So again, I want to thank you very much for listening and for inviting me to be a part of this important forum. Thank you very much, Chair.
Thank you very much, Mr. Hazel. We'll move right along to Dr. Sharon Belmar-George, the Chief Medical Officer, Ministry of Health and Wellness in St. Lucia. And she will give us an update on the trends noted during implementation of the HEARTS programs in St. Lucia. Dr. Belmar-George, welcome.
Good afternoon, thank you. I will share the screen now. Let me recognize Dr. Yitades Chibri, the representative from PAHO, Honorable Malvin Joseph, Minister of Health and Wellness for Antigua and Barbuda, Sir George Arlene, also Dr. Colleen Radix, other PAHO officers and other panelists. Let me first of all thank you for inviting me to present. I also want to recognize Dr. Shanna Sear, our Senior Medical Officer of Chronic Non-Communicable Disease, who was overseeing the HEARTS implementation in St. Lucia. Through HEARTS, we propose to improve the blood pressure control in a cohort of hypertensives in St. Lucia through the HEARTS technical packages, which provides a strategic approach to improving cardiovascular health. These packages are aimed at improving the overall health and reducing the incidence of heart attacks, strokes, and death in persons who suffer with high blood pressure, alone or with other diseases. And these include the healthy lifestyle promotion, the evidence-based treatment protocols, access to essential medicines, risk reduction, a team-based approach, systems monitoring. So in an effort to alleviate the morbidity and mortality associated with cardiovascular disease risk factors, especially high blood pressure, the Department of Health and Wellness in St. Lucia, in collaboration with PAHO, decided to implement the HEARTS technical package in 6 facilities with the hope to implement the modules in all of the primary care clinics across the island in the near future. This is just a pic of our launch of the HEARTS program in St. Lucia at the Bay Gardens Hotel. And that was in October of 2019. So you could see the wide cross-section of our staff members during that launch, which was also followed by a 2-day training at the time. So I'll give an overview of HEARTS in St. Lucia. As I said, in October, it was launched. And during that launch, we did key stakeholder sensitization. At least 120 persons were in attendance. And we also did a 2-day capacity building workshop for the staff. We extended the training to the private sector and physicians and also NGOs at that time. We started in 6 primary care facilities, and the little map shows you where they're located around the island, and we plan to scale up within 6 months. And all of the modules were implemented at the time. As the recommendations for the quiet room for blood pressure monitoring with the nursing staff. Also, we use the validated blood pressure monitors as required at all of our facilities. We've also identified the essential cardiovascular drugs, including the atorvastatin, which is available, and most of the drugs are free or at subsidized cost at our facilities. And also the use of the protocol drugs as well, and the fixed dose combinations as was recommended. Our health education materials was also produced, and also the acceptable and preferred essential hypertensive drug protocols was disseminated to all the prescribers. Our chronic care passport was put in place to aid patients with education and at-home readings. And this came in very handy during our periods of lockdown and shutdown. It provided a guide for patients while they're at home to be able to manage themselves and also to monitor as access to the clinics were limited. We also had a coordinated referral mechanism with healthy lifestyle counseling, continuous training courses for the staff, and monthly team meetings to facilitate coordination. This gives an idea of the staff that we trained through our workshops at various levels, our community health aides, physicians, the family nurse practitioners, health educators, the nurses, nutritionists, and pharmacists were all involved as well. These are just some of the pics of the training, nutrition counseling, and patient counseling through our wellness centers in St. Lucia. Some of our indicators and some of the data from St. Lucia, as I indicated before, we used 6 of our wellness centers, our health centers, and the population, the catchment area for those centers, about 33,423. And from our census, the national adult population is 109,000. It's estimated that about 28% of those would be hypertensive. And the patients with hypertension in the registry within our 6 centers in June was 1,406. When we looked at all of the registries within our 32 wellness centers, it was about 5,813. And through our health management information system, the data that we were able to pull up, we noted that only 39% of those patients showed controlled, that their blood pressure was controlled at the time. And this graph gives an idea of the attendance at the hypertensive clinics for the last 12 months, from June to May. And what is noteworthy, you'll notice that April of 2020, and these are the 6 clinics are there in the colored blocks. But if you look at April 2020, you'll note this is when we had the lowest attendance during that period. And that was when from April 1st to the 7th, St. Lucia had the 24-hour lockdown where we had limited medical services. Our hospitals were functioning, and some of our polyclinics at 4 strategic points around the island. So our network of 32 clinics where we provide diabetic and hypertensive care, and we do dressings, and we do the nutrition counseling, a lot of the support for our NCDs, a lot of those clinics, they were closed during that week. Following that week, we had 2 weeks of partial shutdown where we asked persons to come out, only those who absolutely needed to. And during that period, it was also limited. But we got extremely concerned for our chronic, a number of different conditions, apart from our chronic diseases, our immunization program, which we had worked very hard on up to last year to try to ensure that it was up to mark. So we were very concerned about those patients, also given that the private sector in St. Lucia shut down very early, with some of them offering only telemedicine only telemedicine services. So we noted that the public sector, we definitely had to reopen, and we were able to restructure, because we developed 5 respiratory clinics around the island to ensure care for persons, and we were very strategic to ensure that our chronic disease clinics were not in the same location. So we had to do a level of restructuring and also try to strengthen to make up for those dates when we knew that persons did not get adequate quick care during the shutdown. It was also of grave concern to us, the fact that during the shutdown, a lot of the healthy lifestyle activities were also not available, like aerobics and gyms. And it was a period where we're saying the persons with higher risk for COVID-19 are our patients with chronic disease. A lot of them were quite afraid and just ended up staying in. So the morning walks, the exercise, the gyms, aerobics, most persons just tended to stay in and avoid any extra activity. So not having the full access during the month of April, not having the access to the healthy lifestyles, we definitely noted this reduction in our data. It also shows the numbers. You'll notice the month of April also shows the lowest numbers at that point. Generally, going towards December, we get lower numbers. We know during the month of December, generally chronic disease patients in St. Lucia tend to be non-compliant. So this is a normal trend around then, but it normally picks up from January going up. So we noted that unusual dip in April. Yeah, this just gives the average proportion of controlled hypertensives at the 6 clinics throughout the different months again. And as a support to the hearts, there is also the chronic disease self-management program, which was included in the healthy lifestyle counseling module. This we started in 2015 after some of our key nurses received training as master trainers. And so far, they've been able to train 112 community leaders from the Ministry of Health and other NGOs representing all of the districts around the island. So we've had over 762 persons living with CNCDs, caregivers, and family members have also participated in those workshops. And some have started back in 2020, but because of the reducing activities, we've also seen reduction in those due to the COVID-19 pandemic. Some of the challenges and solutions that we've noted with hearts is a resistance to change from physicians, especially the private sector. We've provided and we've included the private sector in the trainings for training opportunities through hearts to both public and private sector. Also, the inappropriate use of the health management information system, which affects the data that we get out of it. We still get some level of resistance and don't always get that everybody uses the system. And the solution is the development of standard operating procedures to guide its use. And challenges associated with user acceptance of additional duties and protocols, because many times the staff may see it as added duties, as in most of the islands, we have human resource issues when it comes to managing a lot of the community clinics. So what to assist, updating of our job descriptions where possible, ongoing training, and appropriate monitoring and consistent evaluation. Thank you.
Thank you so much, Dr. Belmar George. Thank you for that update on the program. At this stage, we're going to hear from Dr. Hennis again, and this time he will be presenting on the topic recommended modifications for the safe and effective delivery of services. Dr. Hennis?
Yes, thank you very much, Madam Chair.
You're welcome.
Okay, very nice. Okay, fine. So now this presentation will speak a little bit to the impact of COVID-19 and links to NCDs, challenges encountered in health systems. You've heard a lot from colleagues who are sharing their experiences with the challenges that they felt, in addition to some of the challenges I shared before, what is needed, and some operational strategies to address these challenges, giving some perspectives, and then how to build back services better. Let's go on to the next one. Now, again, to establish the context, NCDs in the Americas. There are about 5.5 million NCD-related deaths every year in the Americas, which is 81% of all deaths. So it's the leading cause of mortality in the region. it also is linked to 39% of NCD deaths occur in persons aged between 30 and 70, which means they're premature deaths. So it's one of the most significant causes of dying prematurely when you're at your most productive time of the life cycle. And quite simply, as you can see, the majority of causes of death are because of cardiovascular diseases, as many as 28%, followed by cancer, 20%. Then respiratory diseases, and 7%, diabetes, 5%, and the other NCDs. We can go on to the next slide. I said already, so I won't dwell on this slide about the burden of COVID-19 in the Americas. Let's go rapidly on to the next slide. I'm going to show a couple of slides here just to show the impact of NCDs before COVID in the Caribbean, and really just to drive the point home about this significant burden. So 9 of the 10 countries in the Caribbean, in the Americas, with the highest NCD mortality rates are in the Caribbean. Let's go to the next slide. The overall prevalence of diabetes in the Americas is 8.5%. The highest prevalence of diabetes is about 12% in Caribbean countries. And 9 of the 10 countries with the highest prevalence of diabetes in the Americas are from the Caribbean. In this case, however, women are affected more than are men. Next slide. On the other side, I want to draw to your attention is that the prevalence of hypertension in the Americas is about 17.6%. 7 of the 10 countries with the highest prevalence of hypertension in the Americas are in the Caribbean. Yet again, this time the prevalence of hypertension is higher among men than women. And as you know, all of these statistics and factors and mortality drove the heads of government and heads of state of the Caribbean region back in 2007 to convene in Port of Spain and have the Port of Spain Declaration to improve things and to reverse this trend in the Caribbean. That was in 2007. This is 2020. So I'm just establishing the prevalence and the background for you, and this was before COVID. Let's go to the next slide now. We know, and I've already said this, about the impact of those with pre-existing conditions and NCDs and risk factors in terms of impact in terms of COVID outcomes. And in fact, in the United States of America, there's a 6-fold higher level of hospitalizations and a 12-fold higher mortality in those with COVID-19 and underlying conditions compared to those without. China, 28% of patients with cancer and COVID-19 died, whereas overall background mortality rate was 2%. There are 1.2 million people in this region with cancer. Among those with diabetes, the risk of death or severe case of COVID doubles with diabetes. You have 62 million people in the region with diabetes. Smoking is another risk factor. Let's go on to the next slide. So just ready to bring home the point again about the impact of NCDs and COVID. Now, you said this before, I'll reiterate it. Stay-at-home measures are leading to an increase in NCD risk through unhealthy diets, insufficient physical activity, smoking, drinking alcohol. And some countries have been able to have alcohol regarded as being an important drink to have while you're locked up at home. And they're actually able to have stores delivered to your home. There are some really dodgy studies coming out of France where they tried to make a link between nicotine and smoking and decreased risk of COVID. So there are many things that have been done to try to promote bad behaviors, bad lifestyles, risk behaviors in the time of COVID. Let's go on to the next slide. And of course, we spent some time looking at disruptions in the provision of healthcare services, also linked to closures. But also, as I said before, and we're seeing in the presentations from St. Lucia, Barbados, and Antigua, there's always consistently reductions in attending healthcare facilities or even healthcare programs. And it's linked to not just reduced elective visits and so forth, but people are actually afraid of going out. There's also, as we heard again, reduced cancer care. There's also reduced access to renal dialysis. And so ultimately, there are delays in high priority treatments for patients with non-communicable diseases. And this seems to be linked now as we get more data to excess mortality for some of these conditions in persons because of COVID and fear of COVID. So what we are now seeing is that there are patients who are at high risk of complications and death from diseases which we know how to treat. Next slide. Looking at the background before COVID, we were aware that many of our health systems were weak and underfunded. There's fragmentation of care and poor referral mechanisms at all levels of the healthcare system. There are gaps in capacity of care for NCDs and gaps in the quality of care provided. I mean, not that we aren't reaching to improve, but there exist gaps. Patients often have limited awareness or knowledge about their disease. They may not know enough about how to get the best care. They may not know enough about self-management. And ultimately, it may not be a stretch to consider that some of the poor outcomes we see in this sub-region may be due to some of these drivers, poor disease control linked to poor outcomes. And then, of course, avoidable hospitalizations and cost of care that continue to rise. And it was really sobering to hear the colleague Hazel speak about some of the costs to seek care now in the time of COVID and the cost to charter planes to go get tests and so forth is really very distressing. Let's go on to the next slide. So what is needed during the COVID-19 pandemic? And I've stated here, NCD prevention and management need to be fully integrated into the national COVID-19 response plans, because the first thing that countries do when there's a crisis is to have a national plan. And not all countries have integrated and included NCD prevention and management in the plans. Prevention is important. Prevention is a very, very powerful tool. And I'll use the example of Barbados, for example. When the regulations came down to stop the spread of COVID, there were fines linked to breaking and breaching the rules. And the fines were pretty significant. What happened? People stayed indoors and refused to break the curfews because you have the whole idea of regulation to enforce prevention. Prevention is a really strong tool. And it's in the right context and also in terms of health promotion and education, where people do the right thing for themselves. Now, it's not simply having it in the response plans, but also having it as part of the response, both prevention and management. So it's not just on paper, it's actually a factor in practice. We spoke about the timely access to healthcare and essential medicines for NCDs, which are needed to prevent people getting severe cases of COVID, as we have established, but also to stop people getting out of control. Because clearly, if you're not taking your diabetes medication, you're very likely to have a crisis where you become hyperglycemic or ketoacidotic from not being treated. So, so it's access to care to prevent COVID complications and also prevent loss of control and related complications of these NCDs. Also, I talked a lot about policies to control risk factors. I think it's a really, really powerful tool. Inclusive NCD-related comorbidities in surveillance systems. This is a learning experience for all of us. We are learning of the impact of things like obesity and hypertension and so forth. That is so important, but unless we are documenting and measuring, we will not learn the lessons that are there for us to be taught. And we spoke a little bit about telemedicine to support public health measures as another tool, which has been one of the innovations to go forward. Let's go on to the next slide. Adequate resources for health activities. Obviously, resources include physical resources, personnel, PPE, sanitizer for hands, masks. There are lots of things that have to be done in terms of meeting this new challenge to health. Amend governance and coordination mechanisms to meet the response required. It's taken a lot of changes to adapt. Prioritizing essential health services. And it was interesting to hear the CMO from Salicia speaking about the impact, for example, in immunization programs, maternal and child health, immunization, NCDs, management of infectious diseases like tuberculosis, in some cases, in some countries, malaria, also HIV, are important priority programs. And one has to ensure that there's continuity of care of these health priorities so that you don't lose the gains you've made to date. Also, it's important to optimize the delivery settings and platforms. The whole issue of referral pathways, Self-care interventions, very, very, very important, particularly lockdown at home. Strengthening outreach programs and integrating care. Optimizing health workforce capacity. And I think many countries tend to shuttle people away from NCD care into the COVID response. But by the same token, we have to emphasize the fact that you have to continue to support essential needs because you basically delay provision of care, which will have its own consequences down the road. It's critical to maintain availability of essential medicines and supplies, and we hear a lot about that. And I think this will come up in the discussion a little bit more, as well as strengthening communication strategies. Next slide. This is really just to bring back the slide in terms of what we found about the Caribbean, in terms of countries and how they're implementing strategies to overcome the NCD service disruptions. And this is specific for the Caribbean. And what they thought was very important was trying to identify priorities, telemedicine use to replace in-person consults, novel supply chain or dispensing approaches for NCD medicines, redirection of patients with NCDs to alternate care facilities. In other words, you're now stratifying where people can get care. So people can go to certain facilities to have routine health care, whereas other facilities are being reprogrammed and retooled to look after high-risk patients for COVID. And whole issue then of task shifting and role delegation. Let's go on to the next slide. So in terms of triaging, what really is needed? Well, first of all, before patients even get into the system, they need to be well aware of the fact that they need to come prepared and they need to contact the health system before they come in terms of what is required when they get to the health system. It's no longer walking into the clinic as usual and getting the usual services. If you come to the clinic and you have symptoms, which may be COVID, they need to be alerted before you come so you can be directed for the appropriate services. So information exchange before getting to the clinic is actually really very important. So then when they arrive at the clinic site, there's usually a process in place in terms of the fact they're screened. There may be temperature checks. They have to wear a mask in public places. There's hand sanitizing and personal and hand hygiene. They're usually unilateral flow through the health facilities. So many things have changed significantly in terms of COVID. And these are for infection prevention and control. And what is needed in terms of providing care now is reorganizing physical spaces, making clinics where they are appropriate still a lot smaller, scheduling appointments, avoid crowding in waiting areas, and waiting areas reorganized to ensure physical distancing. So these are things that all of those who are in terms of healthcare provision are well aware of, but these are some of the very basic measures that had to be implemented to tackle COVID and delivery of care. Next slide. Now, there are limitations when you're trying to address triage. You might lack the infrastructure for appropriate triage. If the spaces are programmed in a different way, it may not be possible. Also, the need for hand sanitizer, soap and water, PPE may also be a limitation in terms of dividing the level of care required. What is needed? Clearly, as I said before, the organization of healthcare facilities in terms of processes and actual physical space. We spoke a little bit about unidirectional flow through the health facility. Staff training is so critical. Train, so people recognize the way they have to function in this new normal. So staff need to take the precautions so they protect themselves. Use of PPE for both personnel and patients is now a very fundamental requirement in all healthcare settings. Next slide. Another operational strategy is the whole issue of telemedicine and teleconsultation. What is telemedicine? It really can be defined as interactions that happen between a clinician and a patient for the purpose of providing diagnostic or therapeutic advice through electronic means. It's safe, it's effective to support, the emphasis here is in support management of NCDs, ensuring the continuity of services while minimizing the risk of COVID transmission. So you need a telemedicine care plan. The population in need, defining a strategy for those who have access to the technologies, those who have needs, who have to have access to the healthcare system or community-based outreach access through appointments. So these are the very basic things in terms of having a telemedicine care plan. Let's go on to the next slide. But there are lots of limitations as we're learning. Technology requirements. People have to have a computer. They have to have internet connectivity. Computers with audio and video, conference tools. And what we are seeing quite quickly, as I said before, is the divide in different parts of the community. You find more resources in the bigger cities, and farther away is just not good enough. And we're learning in the Caribbean too, for example, where they're trying to online teaching. The capacity to do so does significantly impact one's ability to deliver these technologies. There are also issues in terms of not just bandwidth, but the legislation for telecommunications. How does one store information or data? Who owns the information? How does one protect and secure information? So it's actually a very complex issue. We've actually been now working with WHO headquarters in terms of trying to find ways to address standardized operating procedures for getting clinicians up and running. Because one day you're sitting in your office seeing patients, the next day you can't see them in your office anymore. What do you do to have a functional telemedicine facility? And that takes training, that takes guidance, and these are the kind of things that we're trying to develop now and working on. There are some listings here on the slide, WHO guidelines and digital health interventions. There are links there. Maintaining essential health services, operational guidance for the COVID-19 context. So tools are available in terms of being able to roll this out. Let's go to the next slide. Novel supply chain. What is this? The need to redirect supplies to treat patients, for example, people with NCDs during a pandemic. So you need to ensure there's continuity of access and supply of essential medicines for NCD management and control. It requires that you have a list of essential services, which includes medicines, diagnostics, and medical devices, distribution centers, because you now have to make sure the processes work. People having access to medications for longer, so you may provide people with medication for 90 days rather than a month at a time. Let's go on to the next slide. What are the limitations to novel supply chain? Shortages. Stockouts are being seen to occur more often. And we also have to monitor patients on their NCD essential medicines to make sure they don't run out of essential stocks. This requires linking list of priority resources with essential services. And you need to develop these protocols so that one is very clear of what the needs are, what you can supply, ensure there's a supply chain, and that patients have access. Next slide. Redirection. What is this? So in other words, modifying the routine way that clinical reviews are carried out. So in terms of frequency and clinical care at non-COVID-19 health facilities. So what one is trying to do is to use the time optimally, reduce the frequency of interactions, but ensure that most appropriate use of health resources takes place in the time of COVID. So you want to reduce the frequency of clinical reviews. You want to ensure there's the provision of medicines for NCD management and to avoid unnecessary exposure for patients with NCDs through clinical management facilities where patients with respiratory complaints are not managed. So again, you're trying to segment the provision of care to facilities where there's a low level of risk of COVID and other areas which are where you direct patients with COVID. So you're trying to stratify where people go for care depending on their risk and their symptoms. Next slide. Healthcare facilities need to be prepared to ensure the protection of patients. You wish to reduce the risk of transmission where people are encountering health management. The whole issue of hospital conversion. Some centers for COVID, some others for non-COVID, you prioritize in terms of risk stratification. Also, you're trying to ensure reach to at-risk groups. So you target the group, so groups who have symptoms or who are at risk know how to get access to the appropriate care for themselves. Another very important strategy is helplines. I think that's made a big difference in countries such as Barbados, where people can call up and get support and help, mental health and all the other issues, and also in terms of where they can go for care. And one has to continue to review care pathways. Next slide. Task shifting. Again, trying to align your staff and health workforce to address NCD management and prevention in the most efficient way. So one might use, for example, health promotion activities through staff promotion. And in fact, there actually are now tools such as the online use of bots, artificial intelligence. And I think WHO is going to be launching, maybe later this week, a humanoid, an online bot who will give counseling for tobacco cessation. Basically trying to maintain access to care for those who need it, but trying to redistribute staff to provide optimal use of facilities. Let's go to the next slide. Limitations. You may not have the staff you need. Staff get ill also, and that also affects your ability. And we've seen in many settings, particularly in Europe and North America to a greater extent, the fact that a number of staff in the front line have become ill or even died in terms of providing care for those with COVID. What do you need? Training, equipping, remuneration is also very important. I think these are things we tend to forget, but one has got to ensure that people can be paid in a timely fashion to support their own family needs. Support and supervision for staff is also very, very important, as well as training. I think a lot of people have not been in a situation where they've had to adapt to the level of demands, and training and online support is also a very important mechanism that organizations are involved in. Next slide. Here's another slide. Wonderful. Oh, okay, just go back one slide. Okay, so basically, how is PAHO supporting countries? We're developing technical guidance and maintaining NCD services during COVID-19. We're supporting policies to reduce the risk factors. And this is a lot of hard work, because what we're seeing is many of the manufacturers of tobacco and alcohol on healthy diets are under the guise of corporate social responsibility, trying to silently market their products. So for example, you have tobacco companies making masks available and even donating ventilators while trying to surreptitiously market their products. So it's a lot of work to make sure we're not losing the public health gains that we have achieved so far. Providing support for communication materials and social media messages to raise awareness for people with NCDs and other conditions, and providing technical guidance and capacity building activities so that people can be informed and know what users will use and what decisions they should make. Let's go to the next slide. Next one. Good, wonderful. These are some of the examples of some of the materials that we're producing. These are for health providers. These are for, next one. Next slide, good. These are some of the materials and NCDs and COVID for the various conditions, what you should do, etc. And these are all available at the PAHO website. Let's go to the next slide. These are other things about if you have asthma, what you need to know, what you need to do. Next slide. Good. And it comes now to the whole concept of building back better. What is that? And one of the persons who spoke a little bit earlier spoke about the fact in the context that is not simply about health. Health does not, I think it was Ms. Griffith, health does not exist as an isolated sector. Health has to engage and interact in a way that there's coherency with what's in the public health interest. And when I say coherency, in other words, the Ministry of Finance might deem it important to sell tobacco for revenue and taxes, but then downstream, more people die from consuming tobacco. So there has to be a coherence in terms of how the country and different sectors of government function in the interests of their citizens. So you have to move in a way so that you have to support the most vulnerable, not leave anyone behind. Many vulnerabilities have been exposed by COVID, by the very low investment in social protection in most regions. We have to strengthen universal social protection systems, and I think Minister Walwyn Joseph brought this up, including universal health care based on a rights-based and vulnerability-sensitive approach The COVID-19 pandemic demands that governments increase investments in public health and social protection systems. For example, in Latin America and the Caribbean, 45% of employed persons have no medical coverage and 54% have no pension coverage. So it speaks to the fact that we need to work at building an entire society, social network and social safety net basket of benefits in the health packages, because this is really how we have to see the way forward with adequate health investment. 6% of public funds must be dedicated to primary health care if we're to find a way forward in terms of investment in health. Next slide. So we have to rebuild a health agenda involving and including those who live with NCDs, in addition to multi-sectoral and intersectoral approaches. We have to develop tools to adapt to the new reality. We must strengthen primary health care. We must build out universal health access. There must be partnerships. We are all part of this, with constructive dialogues leading to comprehensive solutions, and data is key to empower. Next slide, so we leave no one behind. Thank you for your attention.
Thank you very much, Dr. Hennis. You've given us much to think about. At this stage, we're going to move on to the roundtable discussion on the topic Revitalizing NCD Services and Adapting New Modalities to Build Back Better. It is at this juncture that I will hand over to Dr. Patrice Lawrence Williams, Advisor, Non-Communicable Diseases and Mental Health for PAHO WHO, and she will chair this segment. Patrice?
Thank you, Faye. A pleasant good afternoon to all. I adopt the protocol that has been established. In 2007, having recognized the devastating burden and consequences of non-communicable disease on their citizens, the heads of government of the Caribbean community responded to the need at the highest political level, resulting in the 2007 declaration of the Port of Spain, uniting to stop the epidemic of chronic NCDs. Various strategies and evidence-based mandates were defined and some implemented to mitigate the effects of NCDs on the population. 13 years later, we are in the midst of a pandemic, which has adversely impacted the NCD program globally, regionally, and our countries in Barbados and the Eastern Caribbean. So here we are today to look at how we can now build back better services. We can emerge from this stronger than before. With this, I welcome you to the roundtable discussion, for which we have two distinguished speakers. As mentioned by Faye, the roundtable discussion will be focused on revitalizing non-communicable disease services and adapting new modalities to build back better. Not only are people with non-communicable diseases more vulnerable to becoming seriously ill with the virus, but the COVID-19 pandemic has affected their access to services. The pandemic has altered services for the prevention and treatment of cancer, diabetes, and hypertension, and other NCDs. The global assessment discussed earlier reveals that there has been challenges in NCD service delivery, and maintaining existing services and exploring new strategies for this new reality needs to be considered by countries to overcome the barriers identified during COVID-19. The objective of this roundtable discussion is to prepare Barbados and the Eastern Caribbean countries on the course of action to be taken to overcome barriers identified during COVID-19 by sharing innovative ideas, experiences, and relevant strategies, ensuring continuity of services. The discussions will explore innovative approaches based on two scenarios that will be presented to and responded by our expert panelists. So kindly allow me to introduce our two panelists for this afternoon session. Our first panelist is Ms. Maisha Hutton, and Ms. Hutton is the Executive Director of the Healthy Caribbean Coalition, a regional alliance with NCD-focused civil society organizations. She has been working closely with the Pan American Health Organization from 2012 to present, having led the HCC regional civil society organization efforts. Our second panelist is Dr. Carleen Radix. Dr. Carleen Radix is a public health physician and is currently the head of the health unit of the OECS Commission. She has consulted for regional and international public health agencies, including PAHO, and has been working closely with our organization on several initiatives. So at this time, we will proceed with the first scenario. Scenario 1. Resources for non-communicable diseases services has been reduced due to the redirection of funding into COVID-19 response. The government has been unable to allocate additional funding to support the NCD program. Maisha, recognizing the challenges that program and service beneficiaries may encounter because of reduced funding, what are the new strategies and modalities that can be explored to enhance the delivery and utilization of services, including comprehensive screening for risk and disease, promotive and rehabilitative NCD services? We now invite Ms. Maisha Hutton from HCC to take the floor.
Thank you for inviting HCC to provide a regional civil society perspective on scenario 1. First of all, let me say that Caribbean civil society organizations have demonstrated tremendous innovation and leadership over the course of the pandemic, and we have much to learn from them. I'd like to congratulate Mrs. Trudy Griffith on her excellent presentation, which demonstrated the importance of CSOs as partners in health. They fill important service gaps, whether this is to support expanded access to screening services in hard-to-reach communities, facilitating access to treatment and care, again, very often for marginalized populations, providing vital psychosocial care, and undertaking important education through outreach programs. The first point I'd like to make revolves around inclusion. Given resource limitations in the public sector, which are exacerbated by disasters such as COVID-19, it's becoming increasingly important for governments to institutionalize coordinated partnerships between and among civil society organizations. We do see such partnerships across various settings with subventions, fees for services, contracts, but they're often isolated, ad hoc, they have limited quality controls, and they lack coordination with the wider NGO community. So we need governments to formalize relationships with civil society. And in addition to contractual arrangements, governments can promote multisectorality and inclusion of CSOs through national NCD commissions, and simultaneously encourage the formation of national NCD alliances. This also means ensuring that patient voices are integrated into the decision-making processes around policies and programs which serve them. And so once we have this inclusion piece addressed, the capacity to prevent and manage NCDs can be significantly increased. So let's take a closer look at service delivery. CSOs have played a vital role in ensuring continuity of care and uptake of services amongst people living with chronic conditions through the use of novel, cost-effective approaches such as telemedicine, or more traditional communication forms such as telephone or via community outreach, patient self-management, and the promotion of simple, cost-effective tools for standardized home-based screening. Let me share some examples from across the region. The Barbados Diabetes Foundation shifted its service delivery to a largely virtual service at the outset of the pandemic, providing routine consultations over the phone or via conferencing platforms. They also worked closely with patients to educate them about medication adherence and the importance of controlling their diabetes during the pandemic. In Haiti, FATIMAC, a local diabetes and hypertension CSO, utilized community outreach workers and youth leaders to go into the community to provide care for their patients who were concerned about visiting clinic for fear of acquiring COVID. The Belize Cancer Society ensured access to ongoing care for their adult and pediatric patients, including those who were based outside of Belize, through increased advocacy, networking, navigation, and partnership with public and private sectors. The Diabetes Association of Trinidad and Tobago developed a smartphone app for people with diabetes, which prompts, tracks, and provides real-time advice and community referrals when measurements are entered by users. The Bahamas Red Cross used existing service platforms developed for Hurricane Dorian to provide psychosocial support for those affected by the pandemic. And in the midst of the COVID-19 lockdown, the Heart Foundation of Jamaica kept its doors open to ensure continued access to services for its patients. This included access to subsidized medications. Shifting to health promotion and prevention, CSOs have been strong advocates for NCD policies, and they've been working to fill the information gap and promote healthy behaviors amongst people living with NCDs and other vulnerable communities through digital platforms, radio, TV shows, and outreach. The Heart and Stroke Foundation of Barbados and the Antigua and Barbuda Diabetes Association led a Healthy Hampers initiative in partnership with local governments to ensure that people with chronic diseases had access to fruits and vegetables during the lockdown. The OACS and partnered with various CSOs to launch a regional backyard gardening initiative to encourage household-level food security. And the National NCD Commission of Grenada advocated for reduced consumption of alcohol, and the JCTC, the Jamaica Coalition for Tobacco Control, advocated for reduced tobacco use. So I've tried to give you a flavor of the contributions made by Caribbean CSOs in filling critical service gaps in order to meet the needs of people with chronic conditions over the course of the pandemic. In moving forward, what can we learn from COVID-19 in order to build back better? We need to strengthen partnerships with CSOs to improve and expand service delivery. CSOs need to invest in the IT infrastructure needed to scale up virtual service delivery platforms. CSOs must continue to advocate for and support and hold governments accountable for delivering on commitments towards universal health coverage and prioritizing NCD prevention. I was pleased to hear Dr. Hennis's emphasis on prevention policies because the guidance is clear. We have the WHO best buys and recommended interventions. We need to tax unhealthy commodities and earmark revenues for public health. We need to regulate marketing of unhealthy commodities to children to prevent early adoption of unhealthy behaviors. I was very pleased to hear Sir George talk about the rights of the child. We need built environments which support active communities. We need healthy school policies and mandatory front-of-package nutrition labeling. And within the context of nutrition policy, which is key for NCD prevention, front-of-package labeling is a critical enabling policy, which has been shown to be incredibly effective and is currently being discussed regionally. So we need action and movement in that area. COVID-19 has taught us that we have far too many people living with NCDs, and this vulnerability creates significant concerns from a health security and a human capital perspective, especially in the Caribbean with its high burden of NCDs and obesity, both linked to severe COVID-19 disease. We have essentially failed to create environments which protect the public from ill health. Rather, they are incubators for disease, promoting alcohol consumption, tobacco use, unhealthy diets, and limited physical activity. And we are now paying a dear price. We have a unique opportunity now to reimagine a better future. Governments leading through a whole of society approach must commit now to a new transformative NCD agenda to build back better. Thank you.
Thank you, Maisha, for highlighting some very novel and innovative strategies. And so, at this point, let us now take a look at the second scenario. There is a disruption of NCD services due to the lockdown or current public health measures in place. The older adults aged 65 years and over have been asked to stay at home due to increased risk for severe illness from COVID-19. Health facilities are open primarily for the management of COVID-19 cases and emergencies. And in some cases, workers are asked to remain at home or reassigned to work on COVID-19. This question is for Dr. Radix. Dr. Radix, how can service delivery be enhanced and revitalized in situations such as these? We invite Dr. Radix from the Health Unit of the OECS Commission to take the floor. Over to you, Dr. Radix.
Thank you very much for having me. And let me just recognize the presence of Minister Joseph from Antigua and Barbuda, as well as the PWR, Dr. Gebre from PAHO, and Sir George Aline, along with the Executive Director from HCC, and all of my colleagues with whom I work very closely in this region. So in terms of COVID-19 and the disruption in services, and we've certainly heard presentations today that have spoken directly to how COVID-19 has actually disrupted services in our region. And especially when we think about persons who are older and persons with chronic diseases, there's an amplification of the disruption and the impact of disruption on services. So I want to take a couple of steps back and maybe highlight some things that were brought earlier by Sir George and by Minister Joseph with regards to our ability to respond at this time in terms of disruption of services. And it really has to start with how we build our health systems. So having resilient health systems that are adequately financed are part of the key to being able to respond well at the time of crisis. I take us back to the consideration, the 4 points that Sir George made in terms of what a resilient system is. Its ability to be aware, to adapt, and to be able to respond, paraphrasing, in terms of disease. And so strong systems include our epidemiological systems, our being able to be aware and to detect early. And certainly within the Caribbean region, we were able to do that so that our health systems were not as overwhelmed, albeit that there was still some disruption in services. And secondly, being able to adapt. So being able to expand, and Maisha spoke to the role of civil society and the ability to expand or to task shift in terms of human resources when we need to expand services or reach out to persons who may be at home. So here we're talking with elderly persons at home, the ability to tap into community services that are close to home, that are within communities, that already exist, that can be expanded. And when the traditional health providers have to be redirected to crises such as COVID-19. I also wanted to speak to the financing of services, and Mr. Joseph spoke to the medical benefit scheme in Antigua and Barbuda, which allowed for the continuity of supply to members with regards to the NCDs. And on top of that was the use of innovation in terms of supply chain. You know, a lot of public health work is around, you know, boots on the ground and being able to deliver medications to persons in their homes at a time of need. And I'm sure that there were several types of human resource that could have been drawn on by the medical benefit scheme to ensure that persons were able to get their medications at home. Of course, much of what is happening goes beyond what happens at the national level. And so this is my plug in looking at our systems and how resilient they are. We have to take a regional approach. In order to have the kind of give and adaptability within our systems, to have the kind of response for such a global pandemic, and as has been said, a pandemic will come again, it is important that we are able to draw on the collective regional technical experience and the role of PAHO and CARFA in the response has been well noted. Within the OECS Commission, the role of the Pharmaceutical Procurement Service, because we had one central area at which we were supplying some number of essential supplies, we had an eye on what countries weren't ordering when they were caught up with responding to COVID-19, and, you know, helping them to make sure that these items were not lost and those items were available for persons to have in place. So I wanted to say that I wanted to highlight that the kinds of commitments that were made in the Fort-de-France Declaration by our ministers of health in terms of the commitment to sharing resources goes a long way in the ability to build and to finance the types of resilient health systems that are needed, that can then easily adapt and use the type of mechanisms which include telemedicine, incorporating community in terms of the response, ensuring that there's an appropriate supply chain of medications, and connecting with the persons where they are at home, reminding them in terms of behaviors of risk factors and moving the process forward. So I think that for me is just a snapshot in terms of some of the things that can be done in response.
Thank you, Carly, for your great suggestions in responding to the public health measures instituted during the pandemic that has negatively affected the delivery of NCD services and your suggestion of ways to overcome them. So we wish to thank both of our panelists, Ms. Maisha Hutton and Dr. Carly Radix, for sharing their views on how we can revitalize our NCD services and bring in their varied perspectives to this discussion. And just to summarize, as we're coming to a close, and we're going to now open the floor for questions and comments, just to summarize, I'll provide a brief summary of the discussions that we would have had today. We spoke on the prevention and management of NCDs and risk factors and the need to be part of the response to COVID-19, post-COVID-19, and an overall health systems response, particularly in improving management of existing NCDs, a life course focus, ensuring resilience health systems. NCDs has to be at the forefront and prioritizing essential health services. We also mentioned the timely access to healthcare and essential medicines for NCDs, and in particular, how to structure our economies and finance our healthcare system. Our national health insurance should be put on the table in the not too distant future. And this was again highlighted during the presentation from the cancer services. We spoke on maintaining and strengthening policies to control risk factors, particularly in improving our health policy, and the need for NCD prevention and management to be fully integrated. All sectors need to be involved. We need to consider public health approach in management, and we need to consider interagency, intergovernmental collaboration. We spoke about inclusion of CSOs, inclusion of patient voices, and also looking at a broad community approach and networking strategies. We also spoke on changes in infrastructures, especially as it relates to alternative communication strategies, and we mentioned in a couple of the presentations telemedicine, and Dr. Hennis would also have spoken about the organization flow of our physical structures, particularly our health centers. So we wish to thank both of our panelists, Ms. Maisha Hutton and Dr. Carleen Radix, again for sharing with us this afternoon. And at this point, we now open the floor for the audience comments and discussions. We already have some questions that have been posted in the chat, and I will now refer to the questions and direct it to any of our panelists or presenters who can take the floor and respond accordingly. So the first question: as part of the Building Back Better, there is an opportunity for us to place some emphasis on the aspects of the chronic care model. And that would speak particularly to the delivery of community-based healthy lifestyle resources and refer to patient self-management. These are potentially important given the reduced contact patients have with healthcare providers. Is there a plan to focus on these issues, perhaps through the delivery of blended CDSM programs or some other mechanisms? And in addition to that question, there was also another question as it relates to the CDSMP presentation, where Natasha Sobers indicated that she liked the graph on hypertension clinic attendance, and was there a particular reason why there was no reporting from the Barbarian Health Center in October and November 2019? And also, has consideration been given to the online modality of CDSMP? Thank you. Over to you. Perhaps the CMO of St. Lucia, Dr. Belmar, would like to take this question.
Yes, good afternoon all. Let me just answer the part which asked about why there was no reporting from Barbados. It was closed at that point for renovation, so that's why there was no reporting there. The CDSMP programs, it's definitely a program that we are looking to develop even wider, because it allows the patients to manage and be a part of their care. So it's not just a provider giving the care, but they're actively involved in their care and they understand why. And we definitely saw the benefits of that program where family members and community leaders who were trained during the lockdown, they were definitely able to assist their family members and other persons within the community in care. So it is one of the programs that we are continuously expanding, and it has supported and strengthened our diabetic hypertensive program as the patient is able to take ownership of their care within the community. So compliance is much better for patients and their family who've been trained under the program.
Okay. Thank you so much, Dr. Belmar. We have another question to any of the panelists. Do any of the panelists have information on the impact of COVID-19 and its impact on the special needs population and persons with disabilities?
Perhaps I might jump in here if you may permit me, Dr. Lawrence Williams.
Thank you. Please go ahead, sir.
Sure. Well, I think it's important that this has actually come up as a point for discussion, because persons with disabilities constitute a vulnerable population regarding the whole issue of the COVID-19 epidemic. They really have a lot of barriers, for example, barriers to social distancing, barriers to information access. For example, if you don't see well or you don't hear well, information access will be a major challenge. You have challenges with access to care. They often need to have special support, even in the home setting. They have challenges with access even to the work environment or to finances. So there are many, many unique issues in terms of how people with disabilities are able to function in a normal situation, which is even compounded during the time of COVID. So they are more at risk of being exposed because they depend on others for support and for help, and they have specific care needs. So I think the whole issue in terms of how does one support people who have disabilities during the time of COVID, and its support is not only social, but it's physical, it's financial, it's access to jobs and so forth, and even continuity of access to usual care. So there are different players who have a role. Families have a role, carers have a role, and I think there needs to be contingency in place for people who have these disabilities to continue to have care. They also need to have a plan in case they themselves become infected, or people within their community become infected, or their household becomes infected. Governments have a role. So, for example, you see on many of the CNN meetings, there may be people who are doing sign language and things. For example, like having information which can be made available in Braille is also important. Having captions in terms of information that's being produced is also important. Financial support is very important at the government level. People having flexibility to access care or access their job, school, or work is also very important. Having access to personal protection equipment is also important for those who have disabilities. And there need to be targeted measures for this particular group because they're a vulnerable group. Healthcare needs to be accessible, affordable, and inclusive. And I can say a lot more, but I'm just going to highlight those few points. It's really a human rights issue that you have to look after those who are dependent on care. We actually have materials, and I think can share materials in the chat in terms of work that is being done for those who have disabilities, particularly linked to COVID. Thank you.
Thank you. Thank you, Dr. Ennis. So our next question in the chat.
Can I comment on that one as well? May I?
Go ahead, Sir George.
Yeah, there's one group that sometimes gets left out. That is the frail elderly. They're often put in a category and ignored, even not in times of COVID, and especially so in times of COVID. One of the reasons for the high mortality of this group is not just bad care, but no care at all. So one of the groups of which I would make special plea for is the frail elderly, and to insist on the need for the social services to include that group. The Caribbean as a whole has not done well in terms of its older population, even although This is the fastest growing population, according to ECLAC, the fastest growing population in the region. And there's time, the various strategies and plans that have been set out internationally haven't really found echo in the Caribbean. And the presence of a situation like COVID has just amplified the problem that this group of persons has. So this is one group to which I would make special reference as having special needs, and which is especially hard done by in situations like COVID. Thank you.
Thank you, Sir George. And this will lead me on to the next question being posed by the Montserrat reporter. It was great that the first presenter here spoke to highlighting the right of the child regarding the growing ease of them becoming obese. I would like to get a response that along with that, the stress should be equally strong in building the immunity of everyone now, not only in children who are more able right now, with their immunity being on average strong, but to ensure that adults and the elderly be taught and encouraged to build their own immunity. So if I made any sense, so they would like someone to address the thought on how we can move forward in terms of adults and elderly being taught and encouraged to build their own immunity.
If I might, there's been a lot of discussion about the immune status of various age groups. And in fact, one of the theories is that the bad result in the older people is because their immune system's going to overdrive in the recovery phase, and they produce what is known as a cytokine storm, responsible for a lot of the pulmonary and other end organ damage. So there's a lot of debate about the level of immunity. However, a lot of what I have read stresses diet, the need for adequate diet as the persons get older, the need for adequate diet to enhance their immune system. And what is often pointed out, please stay away from the snake oil charmers that sell various pills that are supposed to boost immunity. The evidence that their work is only in the minds of the advertisers. So please stay away from those kinds of, from the snake oil charmers, and concentrate on a healthy diet as being the healthy diet and exercise. I must say, exercise is well shown to enhance your immune status. So the comments would be diet and exercise as being the best approaches to this. Thanks.
Thank you very much, Sir George. Our next question in the chat comes from Beverly, Liverpool. Studies have shown that NCDs, example hypertension, are due to gradual and chronic accumulation of risk factors, example atherosclerosis, that result from inappropriate lifestyle from younger ages. When will the medical community stop referring to NCDs as old people diseases and teach proper lifestyles from childhood? The question is to any presenter. I invite anyone to respond to this question.
Sorry, Chris, the key part of the question is that NCDs are seen is not an old people's disease?
Yes, and we should be encouraging younger persons to be conscious. Yeah.
So the reality is that NCDs begin before one is actually born. It begins in the womb. It's linked to your mother's diet while she's pregnant and carrying you. So we know a lot more about it now than we did before. So it's a life course situation. NCDs tend to manifest usually after about middle age, say middle age, but I mean after age 40. But the reality is it's a life course. So there's a genetic component to all illnesses, which may account for as much as 30% of risk, but certainly one can modify one's lifestyle to prevent or delay developing illness. And NCDs are a prime example of how one could exercise effectively, eat properly, avoid junk food, avoid alcohol, and not smoke. And all of these factors change your whole life course in a positive way. So therefore, The fact it tends to present in most people after middle age is really an accumulation of a number of insults over time. But I think the reality is this: we have to do what we can. I think we recognize, and Sir George talks about the impact of childhood obesity. We started seeing, for example, type 2 diabetes occurring in adolescence, and this is starting to happen about 15, 20 years ago. So it can happen at any age. But the reality is there are things you cannot change, your genetic risk, but you can certainly modify your lifestyle and your risk behaviors from a very early age, reduce the likelihood of childhood obesity, look after yourself, and that makes a tremendous difference. People who stop smoking, their risk starts to trend towards a non-smoker almost immediately. And within about 5 or so years, the risks are much, much better, tending towards those of a non-smoker, a never smoker. So there are many things that one can do to change one's risk by using health promoting behaviors and indulging in a healthy lifestyle.
Thank you, Dr. Hennis. And on
Trace,
that note,
can I just add a quick comment to that? Just not for us to underestimate the importance of the policy environment and creating that environment to really encourage population level change, because leaving it up to individuals to make changes, it's shown that it's ineffective. So we really need to encourage policies, as Sir George and Dr. Hennis have said, prevention policies that create environments that support people to make these changes.
Okay. Thank you, Maisha. And so we have come to an end of our webinar. Very, very interesting and participatory discussions. And so it is my pleasure on behalf of the PWR and the organizing team of the Pan American Health Organization to thank you, our speakers and our panelists who have ably delivered their presentation and have suggested strategies, ideas, and thoughts to catalyze our way forward. We thank the media and the participants who made the webinar a success that it was, and we are now ready to translate the information into action. Special thanks to Sir George Allen and Honorable Malwin Joseph, who provided a solid foundation to commence our discussions. Special thanks to our countries, our focal points and policymakers in the commitment towards the advancement of the NCD agenda. Our NGOs and the patients themselves play a critical role in making strides in preventative actions and prevention of complications. So this concludes our webinar, and thank you once again for attending and participating. Have a good evening.